Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillahirrahmanirrahim. Good day, everyone. I am Muhammad Najmi, PGY 3 dermatology resident from the Armed Forces Hospital, Southern Region. First of all, I would like to thank the organizing committee for selecting my presentation. And I also would like to thank then Professor Dr. Ahmed Nassar for supervising me during preparing this presentation, which is entitled as Solid Glomus Tumor of the Scrotum, an Intraoperative Differential Diagnostic Tip. A 28-year-old single male patient who otherwise healthy has presented with a painful lesion of the scrotal skin. It started about 2 years before presentation. Its size increased very slowly, and the pain was spontaneous and also could be elicited upon touching this lesion. It was relieved by stretching the scrotal skin. There was no history of previous trauma or disease in this site, or medication intake before the lesion appearance. Family history was irrelevant, and on examination, there was a right hemiscrotal skin nodule with normal overlying skin. It measuring about 12 by 5 millimeter, and the pain was intolerable on palpating this lesion. Dermoscopy showed a wide structureless area, which suggests a benign neoplasm versus an epidermoid cyst. Based on the previous findings, we had a long list of differential diagnoses, including leiomyoma, angiolipoma, glomus tumor, neural tumor, and other painful tumors of the skin, and lastly, epidermoid cyst. CBC LFTs and RFTs showed no abnormalities. Ultrasound showed small hypoechoic skin lesion measuring 11 by 4 millimeter, which suggests a neoplasm versus an epidermal inclusion cyst. And then we decided to perform a biopsy. During the biopsy, and while the skin below the lesion was squeezed to control the bleeding, this red gelatinous mass popped out spontaneously. And here is the overlying skin. In light of this observation during performing the biopsy, we limited and rearranged our differential diagnosis to involve glomus tumor, angiolipoma, and epidermoid cyst. The patient reported pain disappearance after surgery and thereafter. Histopathology showed thick-walled blood vessels surrounded by sheets of monotonous cells, and the mass was surrounded by a pseudocapsule. The cells are uniform, penile, and rounded with eosinophilic cytoplasm and basophilic round to oval nuclei. Smooth muscle actin showed positivity. Regarding CD34, it is expressed by the vascular endothelium, but not by the monotonous cells. Desmin was negative. Chi-67 proliferation index is about 1%, which indicates a benign tumor. B63 is negative, which denotes no squamous or myoepithelial cell origin. Clinico-pathologically, the diagnosis is solid glomus tumor of the scrotum. And now the discussion. Glomus tumors originate from the modified smooth muscle cells of the glomus body. They are typically found in subungual areas, fingertips, and extremities, but they rarely arise in other body sites, including the scrotum. They are mostly surrounded by thin pseudocapsules and are possibly connected by thin stalks or cords of tissue to the surrounding tissues. These stalks or cords are easily disconnected by manipulations during biopsy. This may explain the spontaneous and complete popping out of the tumor mass through the biopsy opening. This is our own concept, which the cord simulates the umbilical cord, while the tumor simulates the fetus itself. This table shows an acronym for the painful tumors of the skin, which is comb, hug, flit, bend, and gets back. And as we all know, glomus tumor is a well-known one of them. The take-home message is a clinical tip, which states that whenever there is a painful skin tumor that pops out spontaneously and completely during biopsy, please consider glomus tumor as the first possibility in your differential diagnosis. Thank you.